A very good day to you, good audience members. Uh, I must apologize to you. We're short two members of our panel.
Yeah, I think Dr. Nabila has joined us as well.
Wonderful. Okay, that's one more.
Yeah.
Welcome aboard, Dr. Nabila Zaka. We're just waiting for Professor Zarfishan Tahir. So to our audience members, our apologies. Please give us, let's make it 1 minute in the hopes that Professor Zarfishan Tahir will be able to join. So 1 minute, we ask for your patience, please. So while we're waiting, perhaps interesting little thing to mention, Dr. Borne, our director at APMEN in Singapore, he keeps track of the registrations and so on. And he's pointed out that as of now, it's something like 488 people registered for this webinar, which is a very strong, good figure. And they come from about 80 different countries. So it's very encouraging to see the level of interest coming from all over the planet. It's not our target audience always, of course, is Asia Pacific, but it shows the word of mouth spread and the interest that is being generated, so that vector specialists and the vector community from across the whole planet are joining in, and we welcome each and every one. So wonderful to see that level of interest. Dr. Borne, Amita, I think, we don't want to be impolite to our audience that is ready and available on time. I think we should proceed, if that's okay with you. Shall we go ahead with the...
Yeah, absolutely, Dr. Leo, please.
Yeah.
Thank you. All right, so sorry, I'm just getting myself organized over here. All right, so we're keeping fingers crossed that Professor Zarfishan Tahir, the one member of our expert panel that has not been able to join yet, that she will be able to join, a critical member, wonderful panel that we have available. But to our audience and our panelists and everyone present, a very warm welcome to you all. And thank you for setting aside time to join our APMENxChange talk today. APMEN is an acronym that stands for the Asia Pacific Malaria Elimination Network, and it is a not-for-profit organization with a mandate to support the malaria elimination objectives of its 22 member states across Asia Pacific, fully integrated with APALMA, which is the Asia Pacific Leaders Malaria Alliance. And we have the privilege of having Amita Chebi, our Senior Vice President of APALMA, joining us today as well. So welcome to everyone. Our webinar today is in support of World Mosquito Day, which is observed annually on the 20th of August. It's a commemoration of Sir Ronald Ross's discovery in Secunderabad, India in 1897, that female Anopheline mosquitoes transmit malaria between humans. APMEN has another exchange webinar on Gene Drive on the 22nd of August, next week, Tuesday, again in support of World Mosquito Day. However, our webinar today is a particular highlight.
Voice is not audible.
I beg your pardon? Somebody's saying I'm not audible. Can anyone else confirm that you're having problems hearing me? All right, it sounds like that particular person who said that, just tweak your audio. It may be just a particular problem on your computer. So webinar today is a particular highlight because it focuses on the dramatic consequences that often arise from climate-related emergencies, especially mosquito-borne disease surges such as with malaria, dengue, and other arboviruses.
The problem.
Pakistan suffered the onslaught of disastrous floods last year, 2022, and experienced terrible devastation and massive surges in mosquito-borne disease. But Pakistan rose to the challenge to launch highly impressive responses. Vector control becomes more complex in climate-induced humanitarian emergencies due to the pressure on human and logistical resources, and of course the need to act quickly. You know, it's an emergency, you need to respond very quickly. You don't have the luxury of time. So in this webinar, experts from Pakistan will shed light on their efforts in managing vector control during those recent floods and offer valuable insights to learn from. In particular, we're very fortunate to have with us today Dr. Mohammed Mukhtar, who in his capacity as the Director of Malaria Control in Pakistan, was at the forefront of dealing with this crisis situation. And he is going to share with us some of the hard lessons they learned and the wisdom that all countries should take heed of as climate change continues to impact all nations on our planet. We need to listen to what Pakistan experienced and the lessons that they were able to derive and distill from that experience so that we don't reinvent the wheel every time. Before I introduce Dr. Mukhtar and ask him to give us a short presentation on the climate emergency lessons, let me quickly say something about the webinar process, if you don't mind. The webinar is scheduled for 90 minutes, 1.5 hours. But if the Q&A session is very lively, then we will extend it by another 15 minutes or so for those who are able to stay on. Our audience members are unfortunately muted, I think, and not visible on video, and we apparently cannot activate you for live questions or responses. This is simply a function of the Zoom platform. Our apologies for that. But please be active participants by posting comments in the chat box and questions in the Q&A box. If you take note, questions in the Q&A box, please. If you post a question in the question box, you can also precede the question with the name of the panelist that you would like to have respond to your question. Otherwise, you know, we'll enable any of the panelists to respond to your question. If other members of the audience like that particular, any question, if you scroll down in the Q&A box and you like a particular question, you can upvote that question so it goes higher in the ranking of question, because right at the end, during Q&A session, I'm going to click on the Q&A box and I'll take the questions as they arise from top to bottom. If you have upvoted any question, that question will jump higher in the hierarchy. So please remember that. Please remember that questions must please go in the questions box. We will only monitor the Q&A box, not the chat box for questions. Take note that the webinar is being recorded and the recording will be posted online on the APMEN website for anyone to access, probably in about 24 hours from now. And the details of the website will be made available on your screens. Right at the end of the webinar, don't worry, I'm not going to talk much longer, at least about these kinds of details. Right at the end of the webinar, there will be a very short poll of 3 questions with click options to respond. It takes about a minute to complete, and we ask if you can please complete the poll, as it helps us to understand what we're doing right or wrong and how we can improve. Many thanks for that. All right, so let's move on. The flow of the webinar from now is that Dr. Mukhtar is going to give us a presentation on the Pakistan experience as a case study with distilled lessons learned during that disaster period. Then we will have our panel of 4 additional experts to respond to a series of pre-prepared questions. And after that, we will have the open session of Q&A. where our distinguished panelists will respond to the audience questions. But to all of our panelists, our very sincere thanks for taking time off from your schedules to share your expertise today. We're very grateful indeed. And then also, of course, to our audience, thank you for joining. We hope you are going to learn something and that you will enjoy the experience. Hopefully enjoy the webinar. So let me introduce Dr. Mukhtar, and then we listen to his expert views. Dr. Mohammed Mukhtar is the director of the Directorate of Malaria Control in Pakistan, and is the author of the case study on which this presentation is based. He is a senior vector control specialist who has worked in the field of medical entomology for the last 25 years. One of his core areas of expertise is to investigate the impacts of climate change on vector-borne diseases in Pakistan, mainly focusing on the change in species composition, population dynamics, and geographical and ecological distribution under different climatic regimes. He has vast experience in designing national strategy for the control of vectors of public health importance. He's the primary author of National Vector Control Guidelines and Strategy under climate change-induced humanitarian emergencies. Very recently, he developed a national plan of action for the period 2023 to 2027 for sustainable management of vector-borne diseases in Pakistan, in which climate change has been included as a key factor. Well done. Dr. Mukhtar is the national focal person of Pakistan's first national entomological reference laboratory to meet the research and capacity building needs of the country. Dr. Mukhtar has many other credentials that he could mention, but in keeping with his humble nature, Dr. Mukhtar, he did not list these. Nevertheless, I'd like to point out that Dr. Mukhtar is also the chairman of our APMEN Vector Control Working Group, and I can assure everyone that he is a highly innovative and energetic leader. So thank you very much, Dr. Mukhtar. Over to you, please. Just to mention, Dr. Mukhtar has a bandwidth problem. So kind of keeping fingers crossed that he won't have interruptions with his presentation due to connectivity problems. Yeah, you're full screen, you're up, you're ready to go. Thank you, Dr. Mukhtar. Please proceed.
Yeah. Thank you very much. Ladies and gentlemen, Assalamu alaikum and very good morning. This is Dr. Mohammed Mukhtar. I'm Director National Malaria Control Program, Pakistan. First, I just switched off my video so that to keep my internet connected very stable. Yeah. So first of all, I'm extremely thankful to the APMEN and APALMA for arranging this webinar on a very important topic, the impact of climate change on the vector-borne disease transmission. In today's webinar, Pakistan has been invited to share its experience, which we learned during last year massive floods in Pakistan and its impact on the transmission of the major vector-borne disease in Pakistan like malaria and dengue. So, slide is changing. Can changing the slide? Yeah, sorry. No, it's okay. Yeah. Climate change, as we all know, the climate change is one of the most pressing challenges for the world health community is facing. United Nations has already issued some warning about the rising frequency and diversity of and severity of the extreme weather conditions like heat wave, drought, and flooding as a result of the climate change. The impact of climatic factors, particularly temperature, rainfall, and humidity on the population dynamics of disease-carrying vectors like mosquitoes and sandflies are quite visible around the globe. These climatic variables directly affect the growth rate, developmental period, population size, blood feeding habits, behavior, and breeding site characteristics, and even the introduction of the new vector species in some new area, and consequently the intensity and distribution of vector-borne diseases. Between 2000 to 2018, Pakistan has been, yeah, Pakistan has been ranked the fifth most affected countries which are most affected by the extreme weather caused by the climate change. Country is sensitive to both increase in temperature and rainfall, which could increase the vulnerability for the human health, agriculture, and water resources upon which a large part of economy and livelihood dependent. In last 50 years, this is just a few figures to show how the climate change is affecting in Pakistan on these vector-borne disease incidents. During the last 50 years, the annual mean temperature in Pakistan has increased by 0.5 to 8 centigrade, though it looks a very small increase, but it has a very big consequences on the vector density and its potential for transmission of vector-borne diseases. Number of heat waves days per year has increased 5 times in last 30 years. And it is expected that at the end of this century, there will be the rise of 3 to 5 centigrade rise of temperature in Pakistan, which is a huge rise of temperature, and it's expectation of some experts. Recent heat waves, particularly during the March to April last year, 2022, when temperature crosses 50 centigrade in some part of the country in our history, the most evident example of the climate change. Same, the rainfall has also slightly increased during the last 50 years in Pakistan. And consequently, as a result of these climatic changes in Pakistan over particularly last 2-3 decades, there is a rising and regular outbreak of the dengue fever and malaria outbreak, particularly 2022 in Pakistan, which are the classic example of these climatic variabilities. As I mentioned, that there are two major diseases in Pakistan which are directly influenced with the climate change in Pakistan, that's malaria and dengue. In malaria, Pakistan, a country with a moderate malaria endemicity, made a significant achievement in its efforts toward the malaria elimination. World Malaria Report 2021 recognized its outstanding achievement for reducing 40% its estimated caseload as compared to 2015. However, the devastating floods in 2000 last year severely affected all 60 high burden sharing districts in Pakistan, which resulted in a sharp rise of the malaria cases, reaching to a state of emergency during the month of August last year. If we have the comparison of the caseload of the 2021 and 2022, in 2021, we have 376,000 malaria confirmed cases in the countries, while this number dramatically increased to 1.7 million in 2020-22, which shows that there's a very sharp rise of malaria cases after this flood. However, this number does not include the number of the cases which were treated by other relief organizations. And after the compilation of the data from other organizations, the total number of the confirmed malaria cases last year was 3 million. And this outbreak was recognized as the heaviest resurgence in the last 50-year history of the country. And this slide shows that the country was under the state of emergency for malaria from August to December, when we reported 300 to 400,000 malaria cases every month, while the total number of cases last year was only 376,000. And if we compare the month of January in 2022, the number of cases were only 10,000. But in this year, even in the month of January, we have 112,000 confirmed malaria cases, which indicate the magnitude of the rise of the cases in the country. And this slide shows the comparison of the test positivity rate among the two most malaria as well as flood affected provinces, that is Sindh and Balochistan. And this slide also shows the test positivity rate in these provinces was close to 40% after the August to December. And it ranges from the 24 to 38%, which shows that a huge test positivity rate in our history of the malaria. And this slide, I try to put maximum information about the dengue because there's only one slide for dengue. And I have the two epidemiological scenarios to explain the impact of climate change on dengue transmission in Pakistan. Dengue was first time appeared in Pakistan in 1993, and from 1993 to 2004, there were only 4 districts which were affected by the dengue. However, this number dramatically increased to 145 districts from 2005 to 2020. This shows that dengue is the most rapidly spreading arboviral infection in the country and mainly influenced by the climate change in Pakistan. The population at risk during this period was only 6%, while during this period, it's 100% population at risk. The suspected malaria the dengue cases during this period was only 3,000, while this number increased to 17 million from 2005 to 2022. Confirmed cases were only 700, but in the 300,000 confirmed cases, and number of deaths were only 6 during these 10 years. But for next 15 years, it goes to more than almost 2,000 deaths in the country. And same is case if we have the population dynamics of the dengue vectors. We have the container index ranging from 5 to 22, and average is 11. And same the number of the container and household index was the same, and the visit index. However, these indexes become almost double during this next period of 2005 to 2022. This shows that the dengue, these climatic changes significantly impact the number of the generation and the population size of the dengue vectors, which I explained in my second last slide. And very important, the population per positive adult population, it was only, according to our previous data, it is only 3 specimen per positive household, but it goes to 8, which means that it increased almost 3 times. And this map shows the distribution of the both the Aedes aegypti and albopictus and during the 1993 to 2004 and then 2012 to 2020. And these are the published data. You can see that during this period, the Aedes aegypti was showing the uniform distribution across the country. However, albopictus was limited to the upper part of the country, up to the middle. Few samples were positive, but the southern part of the country was totally free from the Aedes albopictus. However, after 2012 and 2020, the Aedes aegypti albopictus also acclimatized to the southern part of the country, which is the hotter part of the country, which shows that these climatic changes influence the habit, acclimatization habit of the Aedes albopictus, and albopictus also shows the uniform distribution across the country like the Aedes aegypti. And this map and this graph shows the entire story. And this graph is actually the temperature changes in Pakistan for last 120 years. If you look, there is after 2000, there is a sudden rise of temperature in Pakistan, and there are the number of heat waves. And as I told in my previous slide, that number of heat wave days per year was 5 times increased during the last 30 years, which is actually the cause of this high rate of the vector density distribution across the country and the overall the number of cases. So the malaria is dengue is the most rapidly spreading arboviral infection in the country since 2005, and it is mainly influenced by the climate changes in the country. And this slide shows just the magnitude of the damage of the caused by these floods. The country received almost 190% rainfall in last year, which led to a devastating floods. And when we talk about the Sindh and Balochistan province, Sindh received 340% increased rainfall in the country, while the Balochistan received 370%, while the overall country received 190% increase in rainfall, which resulted in the devastating floods in Pakistan. And these floods affected 33 million people, almost 65% of the area of the country. And this flood damaged 2.2 million houses, and over 20 million people have to live in the temporary shelters like the tents and the temporary other places. And these are the 20 million population which actually was challenged for the country for the malaria and other vector-borne disease point of view. And overall, this slide shows that there was estimation of the 30 billion US dollar reconstruction cost and economic damage, which is equivalent to 10% of the total GDP of the country. So you can imagine the magnitude of the flood and its damage caused to the economy of the country. This is my main slide, which I want to explain we have the lesson learned during these emergencies. The main lesson learned, which I have enlisted 10 major lessons learned. Mainly, it's the 6, but there are the other 4 or 5 minor lessons learned. But mainly, it is the inclusion of what we have the lesson learned that they include the malaria and vector-borne disease in this all strategic, operational, and financial planning of the humanitarian emergency. We developed our national strategic plan in 2020, that was actually 15 years, but unfortunately, we could not address the humanitarian emergency response. Or if there is any problem in the country, how to respond to this humanitarian emergency. So we are going to revise our national strategic plan. We have revised last year, and we have included the humanitarian emergency, keeping in view our very bitter experience of last year's flood in Pakistan. Similarly, based on the lesson learned from this flood, we have also updated our National 5-year Plan of Action for Vector-Borne Diseases from 2023 to 2027. And there is one complete chapter addressing the humanitarian emergency response. So the country is on well track to address, if God forbid in future, if the similar situation happened, we must have some planning in our pocket to address this emergency situation. Second, allow the flexibility of selection of vector malaria.
It looks like we may have hopefully temporarily lost Dr. Mukhtar. Let's be patient for a minute. Hopefully Dr. Mukhtar will rejoin us soon. So let's just give him a minute. Hopefully he did say beforehand he's got connectivity problems. So please, let's just allow him a minute or so to rejoin. Sorry about that. But I think you will agree with me that what Dr. Mukhtar is sharing with us, reflects a very tragic, devastating experience that has afflicted Pakistan. So, and hats off and great respect to how Pakistan responded to that great emergency, going from an average...
Dr. Leo, are you hearing me? Sorry, are you hearing me?
Okay, yes, good. Please proceed, Dr. Mukhtar.
Yeah, sorry, Baba.
Please proceed, yeah.
Yeah. I was on the final slide. Yeah. So the second, the major lesson we learned, that allow the flexibility in the selection of the malaria and other vector-borne disease control tools. You know that there are only 2 core interventions as per WHO guideline, that ITN and IRS. During this natural...
Yeah, no, sorry, there was a problem with the slide deck, but you're on the appropriate slide now. Sorry to interrupt you. It's actually not on the correct slide. Please just take this
Sorry, I'm at the last slide for lesson learned.
We're not seeing that slide, Dr. Mukhtar.
I will tell. Oh my goodness! Oh my goodness!
Take your time. Take your time. There we go. Okay, we're back on track. No problem. Please go ahead, Dr. Mukhtar.
Yeah, I'm just sharing the full screen mode. Are you here? Are you able to see my slide now?
Yes, and we're on the correct slide. Lessons learned.
Okay. So thank you very much.
No, you've jumped to the last slide. So go back 1 slide.
Okay.
There we are.
This one?
All right. Okay.
Yeah.
You're on the right slide.
Actually, Actually, this slide, I explained the magnitude of the damage which caused by these devastating floods. And you know that the country received 190% more rains in last year. And when we speak about the individual provinces, the Sindh received 340% more rain and Balochistan received 370% more rain, which result in a devastating floods in the country. And as a result of these floods, almost 20 million people have to go live in the temporary shelters because it caused the damage of the 2.2 million houses. So when we estimate the loss to the economy of the country, it is almost 30 billion US dollar, which is equal to 10% of total GDP of the country. Which now you can imagine the magnitude of damage of this flood in Pakistan. And Pakistan is, you know, that is a developing country. For developing countries, such magnitude damage makes something very, very dangerous for its economy. Now I've moved to final slide, lesson learned, because I know that we have a very short time constraint. And I explained the first that include the malaria. What we have the first lesson during this flood emergency in Pakistan, that please include the malaria and other vector-borne disease in all strategic, operational, and financial planning under the humanitarian emergency response. Because we developed our national strategy plan in 2020, but unfortunately we could not address this humanitarian emergency response in that strategic plan. So that's why last year we revised our national strategy plan and we include this humanitarian emergency if God forbid it happen in future. Secondly, we have also updated our 5-year plan of action for the sustainable management of vector-borne diseases, and there is a complete chapter of the climate change and its impact and human and the control of the vector-borne diseases under humanitarian emergency response. Second most important lesson was allow the flexibility in selection of the malaria and other vector-borne disease control tools. You know that there are only two core interventions, IRS and LLINs. And during this natural disaster, 60% population of the affected area have to move to the temporary shelters like tents, where we distributed the bed net, but unfortunately, due to smaller size of the tents, the people community was not able to use to install those bed net in their tents. And second, those tents the bed nets were rectangular shape, which is make it impossible to hang these bed net inside the tents. So as a lesson learned, we make the recommendation that the program should also have the conical shaped bed net in its pocket if this similar situation happen in future. Second, we have no plan for the IRS under for these affected areas. But after this emergency, we plan the IRS with the help of WHO, with the help of Global Fund, and we make a very good response to the IRS, and which is our main lesson learned, that we should have the flexibility and we should maintain the balance in the different intervention, either through IRS or through LLIN or in combination where it is appropriate. We also use the BTI first time in Pakistan, which shows the outstanding results in the control of the larval stage of the mosquitoes. And we also make the mass drug administration. So there we make some flexibility in the selection of the malaria and other vector-borne disease control tools. Third was the implement and integrated community-based centered humanitarian emergency response. This was very important because of that there are different organizations have their own plans. So what we have the major lesson that all these emergency plans should be integrated under one national plan, so that we can make a speedy response to these situations. And IVM, integrated vector management, is the best strategy for under such situation. We should not focus only one intervention. We should try to use all possible intervention in a most compatible and cost-effective way to make some better impact of these intervention. Fourth one, the collect and share the data. As a national program manager, this is the major challenge for us and the major lesson learned which we got during this emergency. There are different organizations working in Pakistan independently. there was a very weak mechanism of coordination, which resulted in the duplication of resources and the wastage of resources. That's why we may have a very big lesson learned that we should have we should collect and share the data for the evidence-based decision making and accountability. And the fourth one was the increase the funding flexibility for malaria response under the humanitarian emergencies. This is very important that there is need of flexible funding mechanism for malaria and other vector-borne disease under the humanitarian emergencies involving the non-governmental organization, NGOs, and private sector. This could enable the program for the rapid procurement of commodities and services. Government should also enhance the domestic resources, which is very important for our lesson learned for us that we should not rely only on the donor support. We should also enhance the domestic resources first to ensure the sustainability, to have a rapid response for under these climatic emergencies. So under this point, we also have a very good lesson learned that the government should also enhance its domestic funding and reduce its dependence on the donors. Then very important, support the development, procurement, and deployment of new malaria and vector-borne control tools for the use of emergency setting. The country must engage all partners, industry, policy makers, and the product development consortia to promote the investment for the new tools development and really addressing the need of the emergency response. To ensure the quality control, there should be a fast tracking and sophisticated system of the registration of the product in the country and under some regulatory authorities. And regulatory authorities can also issue a one-time waiver for the pharmaceutical and the other health products which are not registered in the country. So this will help us because sometimes the product is not registered in the country, but that is really need under the emergency. So there should be the what we lesson and to address this lesson, we are now having a very strong coordination with Drug Regulatory Authority Pakistan for speedy registration of these products. And the seventh point, which I have already explained, that they enhance the domestic funding and reduce the donor dependency. Only quality control product, quality assurance product should be used in the country under this with the consultation of national authorities, and there should be local procurement under humanitarian emergencies. This is very important because during these flood emergencies, we were importing the bed nets from the India, while the bed nets were also produced in Pakistan. However, due to certain restrictions on the local procurement, there was a delays in response, and we have to depend on this import of the bed net from other countries, while those bed nets were produced in Pakistan. Scenario-specific intervention and product selection. As I already explained, that we distributed rectangular-shaped bed nets among the affected population, where they are living in the tents, where these rectangular bed nets cannot be used. So those bed nets which were provided remain unused by the communities. So we should promote the conical bed net as well in our pocket, so that if similar situation happen, we must have the scenario-specific product in our country for to.
Oops, okay. Looks like we've lost Dr. Mukhtar again. Let's give him a minute or so. As mentioned, we've lost Dr. Mukhtar. Previously, it didn't take.
So I have completed my final slide. I think you missed the final slide, my final slide.
Dr. Mukhtar, you got 2/3 of the way with the penultimate slide, going through the list of 10 lessons learned. Do you want to quickly run through the remaining 2 or 3 bullet points on the previous slide, the 10 lessons learned?
This one?
No, the one before. This is your final one, the one before. This one. I think, yeah.
I think, yeah. Are you able to?
Are you finished going through this list, Dr. Mukhtar? All right. All right. I think we've had time to read through the final bullet points anyway. So I think we've gleaned the lessons that Dr. Mukhtar wanted to share with us. And I think we can stop this presentation and move on with the rest of the webinar. So Dr. Mukhtar, I'm not quite sure when you're going to get back on, but just to thank you so much for that presentation. What an absolutely excellent overview that fully brings home the scale of what Pakistan was confronted with, going from 300,000 malaria cases in 2021 to 3 million last year. Very, very severe consequences that Pakistan, and with a great deal of help from the personal contributions of Dr. Mukhtar in his capacity as national director, how they responded to that emergency very rapidly and very professionally and very effectively. So our great respects to Pakistan. Well done. There's an example to emulate, and preparing for us these lessons that were gleaned that we can all take home and apply when these things happen elsewhere, as they will happen elsewhere in times ahead. So thank you, Dr. Mukhtar. Please, can I ask our panelists, please could you turn your cameras on, video, please on. Our organizers have asked that all our panelists should now activate their video. I'm going to introduce our other members of the panel, expert panel, who will discuss and respond to questions. So we're very fortunate to have the following 4 dignitaries to help improve our understanding. I'm not quite sure, Dr. Borne or Mulan, can you tell me, has Professor Zarfishan Tahir, has she been able to join? Hopefully, but let me introduce her because hopefully she'll come on board with time. Professor Zarfishan Tahir holds a PhD in public health and epidemiology, a master's degree in microbiology, and a bachelor's degree in medicine and surgery. So she's a qualified medical doctor on top of everything else. She's a highly esteemed faculty member at the Institute of Public Health in Lahore, where she serves as dean. She has worked in many projects in collaboration with the World Health Organization. She's published 45 peer-reviewed journal papers and attended many international and national conferences or workshops. In collaboration with the Directorate of Malaria Control in Pakistan, her Institute of Public Health in Lahore has been investigating the impacts of climate change on vector-borne diseases in Pakistan to develop and launch innovative technologies to mitigate these impacts of climate change. Very recently, the Institute of Public Health in Lahore developed the Provincial Entomological Laboratory as part of the National Entomological Reference Laboratory, which focuses on mosquito taxonomy, vector management, insecticide resistance assays, and other things, and providing technical assistance and guidance for designing national policy and strategy. During the floods in 2022, Professor Tahir was intensively involved in the situation analysis and future consequences of climate change in Pakistan. Welcome, Prof. Tahir. Thank you for taking time to be with us. Hopefully you are with us. Then our next panel member is Dr. Nabila Zaka, is the Pakistan UNICEF health manager. She has a medical background with a master's degree in reproductive health management from the United Kingdom a specialization in gender studies, and a PhD in medical anthropology. She's worked with UNICEF in Pakistan, Afghanistan, East Asia Pacific, and at the New York headquarters. She led the flood emergency response together with the Chief of Health for preparedness and preparation of HAC appeals, resource mobilization, and documentation for periodic situation reports. She coordinated the response efforts with the Directorate of Malaria and other vector-borne diseases control agencies in Pakistan. I apologize, but we're overextending our time allocation. So I'm going to cut out some of these wonderful qualifications just in the interest of time, but just also to mention that she was responsible for development of the Joint Action Plan for Flood Emergency in 2022, together with WHO and UNFPA. We also have the privilege of having Dr. Qutbuddin Kakar, who is a National Professional Officer for Malaria and Neglected Tropical Diseases in the WHO Country Office in Pakistan. Dr. Kakar is a physician, an epidemiologist, and a malariologist with a master's degree in tropical medicine from the Liverpool School of Tropical Medicine in the UK. So he has vast experience in dealing with the prevention and control of malaria, dengue, and leishmaniasis, all the way back since 2002. He's been involved with the national program, all for the case management and vector control during these flood emergency. Dr. Kakar was a focal point in the WHO Pakistan office during this malaria outbreak period last year. We move on to Dr. Mohammed Tariq, who is an associate professor in the Department of Entomology, PMS, Arid Agriculture University in Rawalpindi, Pakistan. He completed his PhD at Imperial College in London and obtained a master's level qualification from Harvard University. He also has qualification from the Pirbright Institute in the United Kingdom to work with pathogen-infected mosquitoes. And Dr. Tariq is in charge of the newly established Pakistan National Entomological Reference Laboratory in collaboration with the Directorate of Malaria Control. Again, I apologize. I'm going to not complete the full qualifications of each of our very prominent panelists, but just to say to the audience, these are highly qualified people with vast experience, and it's a privilege to have them participate in this webinar and to have them available to answer some of our questions. So this APMENxChange webinar takes a slightly different format to our usual APMEN Vector Control Working Group webinars that many of you will have participated in. And the question and answers session has two elements. We start with some pre-prepared questions for our panelists to kick off the background information sharing. And then after that, we will respond to questions from the audience. So we'll start off with the pre-prepared questions. I can't remember how many there are. I think about 7 or 8 or so. And the first question is directed to Dr. Mukhtar and Dr. Tariq. I'm going to read the question and ask Dr. Mukhtar if you will be the first of the two of you to respond to the question. You respond, and then Dr. Tariq can respond as well. So the question is, how has climate change influenced the prevalence and distribution of vector-borne diseases, generally and particularly in Pakistan? Are there any specific vector-borne diseases that have shown a notable increase in frequency or intensity due to climate change? Over to you first, Dr. Mukhtar, please.
yeah, बंद कर देना.
If Dr. Mukhtar has, no, I see you have
sorry,
rejoined us.
I'm not changing my place because with my place there is a power shortage. So that
Dr. Mukhtar, can you hear me? You coming
yeah,
through?
I'm there from the different place with Dr. Tariq, because from at my place there is a power shortage, and due to the electric the net is disconnected. So
Okay.
yeah, I'm hearing you.
All right. Thank you, Dr.
Hello.
Mukhtar. Thank you for that. I'm not sure. Did you hear my question? Are you able to respond to that, Dr. Mukhtar?
वीडियो बंद रहने देना, इसको ठीक चले. Hello.
Dr. Mukhtar, did you hear my question? Are you able to respond to that question? Dr. Tariq, did you hear my question?
Oh, they're disconnected.
Okay, I'm going to move on to our second question, which is directed again to Dr. Mohammed Mukhtar and to Dr. Qutbuddin Kakar. Maybe Dr. Kakar, if you wouldn't mind responding, if Dr. Mukhtar still hasn't made good connection.
Thank you. I think if you can hear my voice, I think we have the same problem of internet in the far-flung province of Balochistan, Pakistan. I am right now in Balochistan in the Institute of Public Health, interacting with the care providers from the outbreak hit districts.
All right. So we have a problem. I'm assuming this is Dr. Kakar.
Was that, you know, they by how
No, Dr. Kakar,
what
we are,
you know, the climate change has
Dr.
affected
Kakar,
the epidemiology
Dr. Kakar, if you can hear me, we cannot hear what you are saying. So you have a connection problem.
Can you hear me?
It sounds like it may be better. Try again.
Can you hear me, Dr. Liu?
It sounds better. Is that Dr. Kakar?
Yes, it's me.
All right. This sounds better.
Could you kindly just repeat the question? You know, the question which I heard was about the impact of the climatic change on the malaria and VBD's epidemiology. If I heard that, you know, it was the question like this.
I'm sorry, but from my screen, I can't see who's speaking. Can I just confirm, is this Dr. Qutbuddin Kakar I'm talking with?
Yes, I'm talking. I'm talking. Do you hear me?
So the question to you, Dr. Kakar, is actually our second question. In the case of the Pakistan floods, what were the primary challenges faced in implementing effective vector control measures? How did you overcome logistical hurdles such as accessibility to affected areas, resource constraints, and while managing the vector control in the emergency? So explain to us some of the challenges that you were confronted with us and how you dealt with that, if you don't mind, please, Dr. Kakar. Dr. Kakar, did you hear me? I see a note here on the screen. Dr. Qutbuddin Kakar's network bandwidth is low. So may I ask our panelists, who can hear me and who is able to respond? Who do I have contact with?
Dr. Nabila is here.
I'm sorry?
Dr. Nabila Zakri is here. So,
I can't hear you either, Wulan. It's very unclear. Say again?
Dr. Nabila Zaka is here, and I can also hear you well.
I can hear you say Dr. Nabila Zaka is present. Who else, Wula?
And also Professor Zarfishan.
Ah, okay. Professor Zalfishan has also joined. That's wonderful to see. So, okay. So let me go to the question here that was directed to Dr. Zarfishan Tahir, and welcome aboard, Dr. Zarfishan. Thank you for joining. And Dr. Nabila Zaka. How can communities be actively involved in vector control efforts during such emergencies? And what benefits does community engagement bring to these initiatives? So I'll ask Dr. Tahir first to respond, and then Dr. Zaka can add on or give her perspectives. So how can communities be involved in the face of such emergencies? Would you mind sharing some of your thoughts, please, Dr. Tahir? We seem to have a serious problem in our connections with Pakistan. Sorry to our audience, we're trying, promise you we're trying hard. Dr. Zaka, it seems that we're having problems in connecting with Professor Tahir as well. If you can hear me, would you mind trying to respond to that question on community involvement, community engagement? Please, Dr. Zaka.
Thank you, Dr. Leo. Am I audible?
Beautifully. Yeah, wonderful. It's good to know at least one of you is able to communicate. Please go ahead, Dr. Zaka.
Okay. I think just to reconnect with Dr. Mukhtar's excellent presentation, though, we are already prepared for emergency and we try to minimize the damages, But still, I felt, during 2022, that during the whole of the flood emergency, the vector-borne diseases were another emergency within it. And really the kind of preparedness that we were used to, considering the caseload and the issues that he highlighted, it went far, far beyond, what was expected. So it's really important that community networks are engaged and prepared and involved in the vector control efforts. So from UNICEF side, what I can talk about that we had a two-pronged approach. One was to have risk communication and integrated social mobilization through our social behavior change communication team. That those efforts were used to reach and involve communities. There were messages through mobile phones, and there was also a mapping done in the earlier assessment, in the rapid assessment, like what kind of communication tools were available to the community. So most people were relying on mobile phones. So to be consistent with that, the messaging from mobile companies, were used. And also radio messaging, mosques and other places of worship were used. Schools and health outreach and facility-based services were all employed to disseminate key messages of prevention and how to use insecticide bed nets, how to remove, stagnant water if it's in their capacity. Of course, initially it wasn't. And also involve communities in the response. And this meant that we were also using multiple channels of communication to reach a different target audience, but also at the same time reinforcing the messages. So there is more consistency and more uptake. And I think that was very, very important to build trust in the communities, that what government is responding to and what's expected of them, and also have uniformity of messaging and catalyzing local action and activism. So initially, when we started our response, one of the important channels was use of peer volunteers or community mobilizers who were hired and asked to serve the camping population as well as through the outreach services. And the insecticide-treated bandits were provided, and their optimal use was also promoted through those mobile outreach services. And we were initially more focusing on families with children under 5 and pregnant women for early distribution. This role by peer volunteers was later strengthened by more systematic engagement of outreach medical teams that we employed as part of our emergency response, and also use of the lady health workers that are community-based workers in the government system. So I must say that the community engagement helped us in many, many ways. It helped in fogging activities. It helped in creation, looking at the communal spaces, and also identification of households that are most vulnerable. And awareness efforts ensured that families were also seeking care in a timely manner. So while we were, as Dr. Mukhtar said, that we were having, more than 1 million cases through the public health facilities registered, but there were also cases that were coming to other philanthropies through the private sector and all that. And they also needed treatment. So there was also that kind of an emergency created that suddenly anti-malarials and antipyretics were out of stock. So I must say that unless and until, the ministry and UNICEF and other partners consolidated their efforts, there was no chance that we could really reach out in a timely manner, but we did. And we potentially averted 100,000 of those deaths. And then also UNICEF did this community feedback mechanism through SMS, where a short survey was sent to the people in the affected districts, and they responded. And this was established to monitor the quality of response and any unmet needs. So this also included, the actions and feedback on the vector control activities. Thank you so much.
Dr. Zaka, that's wonderful insight. But, I can't help, I'm standing on the outside and I'm trying to get a grasp of what it must have been like being there in the midst of what could easily and what must have at stages been chaos. So it's a fine line one has to walk to try and maintain order in what would naturally otherwise be total chaos, given the devastating conditions that prevail. So, again, great respect and compliments to the way Pakistan dealt with this emergency, but it's not easy. So I want to ask you, Dr. Zaka, can you give us some idea of or give us your opinion, if you have different organizations, some government organizations, some NGOs, how does one promote coordination and, coordinated effort between the different stakeholders to minimize the risk of wastage, to coordinate the efforts to support? Can you give us some sense of what happened there to partnership between government departments and NGOs and civil society and donors to enhance the vector control and other efforts? What happened there?
Thank you, Leo, for that question. Totally agree with you that coordination was extremely, extremely important. And let's be mindful that in this 2022 emergency, the usual cluster approach of humanitarian response was not initiated. So it was the ministry who was coordinating all efforts under National Disaster Management Authority. and the provincial disaster management authorities in provinces. And, so WHO led the response together with the ministry, and we as partners, especially on the health side, mostly UNICEF and UNFPA, we tried to develop a joint action plan, categorically saying, in which district, what are we doing, so that we don't duplicate our efforts. And we had also massive flooding in 2010, though it was far less devastating than the last one. But everybody said that the funding that the country received was just 10% of the funding that they received in 2010. So you can also imagine the resource constraints, and Pakistan was also going through the economic crisis at the same time. So going back to partnerships, I think it was really important. Why, and what I really liked in the ministry's response was that though we had daily, face-to-face meetings among key partners in health, but we also had a WhatsApp group through which the information flow was really swift and the actions could be quickly taken. So all the IDSR reports, all the malaria reports, they were coming onto that WhatsApp group as well. And we could triangulate the findings and also consult more with our program, government partners to say where is the need. And also to say that though we had excellent coordination among partners, but there was a lot of ambiguity. Sometimes we would hear that, there is ample amount of this commodity or this drug, but when actually you need it, it is not there, it's in pipeline. So we also felt that some kind of a dashboard, where everybody could see, and it can be maintained by ministry and the malaria directorate or vector-borne diseases directorate, would be very, very useful to see what is in pipeline, what is in the warehouses, where is it located, and how we can move it as one response. So I think it was a learning by doing, and we can go from there. But also warehousing also became a real challenge because, these bed nets are very, very bulky and they occupy a lot of space. So as soon as the containers arrive on the port, and then you have, from health side, we were feeling that, I would say, push that, your commodities are taking a lot of space, and quickly do that, quickly distribute. And then the logistical capacity of sometimes, our partners on ground is not that great. So that's also an issue. Dr. Mukhtar also talked about, the role of regulatory authorities and the liaison, at different levels of government for bringing in procurements and, giving these waivers. So that also needs to be, now that, we are past that, we can have time, to really look at that and to see, how we can make improvements so that next time we are not facing the same. And in that regard, from UNICEF side, we are working with our supply division to look at, what can we procure locally. And we are also partnering with the directorate in ministry as well as the regulatory authority. So, and then as you talked about the, the different partnerships, to sum it up, it's also like, that we build new alliances to see, okay, where are our needs, who can help us, how we can bring complementarities, but also, we use the existing networks and the existing mechanisms to strengthen the response further. And lastly, I would want to talk about the partnership with the private sector, which is one of the key pillar considering resource constraints. And also in Pakistan, we have a very thriving private sector. But then we have the issues of like whether we can procure locally, whether they are registered, whether there is a pre-qualification or not. And of course, the private sector can help in providing financing, expertise, research, leveraging and other means, and also engineering technologies or biological controls that may be needed. And we also saw examples of drainage of water in certain areas with civil work organizations and other country teams as well who came to Pakistan to support. And with Malaria Directorate, UNICEF is currently working on exploring the use of drone technology for different means, for conveying commodities or for fogging. So that's ongoing. And I would also say that considering the importance of this webinar, it's like one of the peace and knowledge management and lessons learned. And these are important investments. So whatever we do for partnerships, we should keep a component of knowledge management in it. Thank you.
Dr. Zaka, thank you for that fascinating explanation. Words of wisdom, words of experience coming from someone who walked through the fire and survived and has many lessons to share. Very valuable insights that you've provided there. So thank you for that. Very, very important insights you've provided there. I'd like to ask if Dr. Mukhtar, are you back with us, Dr. Mukhtar? I think you were sharing a computer with Dr. Tariq. Can you hear me, Dr. Mukhtar?
Yes, Dr. Leo, I'm there. I'm on my separate place, a new place where the electricity is there. So actually, there is a very big, huge rain going on in Islamabad, due to which there is some interruption on the electricity and there is internet connectivity. So I'm there.
Well, I'm hoping it's not the start of another flood, and I shouldn't even say that. Yeah. Dr. Mukhtar, now that we have you back on board as also Dr. Tariq, I'm going to try and speed up a bit because we need to give time for the audience questions as well, and we're running out of time. So the question I had directed to you at the start before we lost contact, how has climate change influenced the prevalence and distribution of vector-borne diseases? There's the historic situation, particular species prevailed in particular geographic areas at particular levels of abundance. Has that changed? Are there any specific vector-borne diseases that have shown a notable increase? Can you talk us through some of the things that changed during that major flood event? Please, Dr. Mukhtar.
Yeah, thank you very much. This is a very important question. If you, the audience have seen my early slides, that the climate, I explained how the climate change has directly affect the major vector bodies in Pakistan, like the malaria and dengue. And you know that as I also explained, that there is a rise of temperature in Pakistan 0.5 to 0.8 centigrade. And though it looks a very low rise of temperature, but it has a very big, significant impact on the population of the vector density. Number of generation increase and the rate of feeding of the increase and the number of new species introduction, population size and feeding behavior. All these behavior of the mosquito population dynamics is changed when there is slight rise of temperature. However, in Pakistan for last 30 years, there is a continuously increase in the temperature, and there is a heat waves in Pakistan, as I explained my slide, and that's why there is a rise of the vector bodies, particularly dengue, particularly, and malaria generally as well. Last year, when there was a flood in Pakistan, we have a very big mission in the field with the WHO team and WHO regional team. We have a very big situation analysis mission in Pakistan, and we found that from these flood affected areas, we could not find a single specimen of the major vector species, that is Culissifacy, but we found the Anopheles pulcharimus. Out of total specimen collected from this area, from the flood affected areas, 98% was Anopheles pulcharimus, which was surprising for us that how this big change in the vector population or vector dynamic population dynamics in Pakistan. And definitely we collected those specimens and linked with the climate change, and we found that the maybe due to climate change, our primary vector, that the Culis species, totally wash out from the flood affected areas. And there is a new vector species that is Anopheles pulcharimus, because the 90% of total collected samples were Anopheles pulcharimus. And we set the sample for in CDC Atlanta for their blood analysis, for some other analysis. And I particularly, as you said, is there any specific disease in Pakistan which is after this climate? Definitely, the dengue is the most important disease after this climate change in Pakistan. Because as I explained in my slides, that since 2005 we are facing the regular outbreaks of dengue in the country, and when we analyze the climatic data of the country, there is a constantly rise of the temperature and heat waves, due to which the vector population is building up in the country, and there is a high incidence of these vector-borne disease in Pakistan after this the climate change in Pakistan. So definitely these climatic factors have shown a notable impact on the transmission of the vector-borne disease, a frequency and intensity of these vector-borne disease, particularly dengue and malaria in Pakistan. Over.
Thank you, Dr. Mukhtar. Fascinating. And again, it shows the importance of vector surveillance. I mean, that's a major shift, from Culissifacies as the primary vector that we all assume is a static factor. If it will always be the primary vector, and yet experience shows that there can be a dramatic shift with associated consequences of something like Pulcharimus taking over as the primary vector. Thank you for that. And also the point you made about dengue. And we've got to keep our finger on dengue. It's going to be the next malaria in Asia Pacific. And we need to be more aware and conscious of dengue in all the countries in Asia Pacific. So I'd like to give each of our panelists an opportunity to address a question. So I'm abandoning the original sequence and I'm jumping around, and I'm only going to ask two more questions from our panelists before I go to our audience questions, in the interests of time and in fairness to give some attention to our audience questions as well. So my question is directed to Dr. Zarfishan Tahir. And then maybe I'll ask Dr. Tariq to respond as well to the same question, but primary response from Dr. Tahir. Professor Tahir, are there any innovations that have shown promise in enhancing vector control measures in emergencies? And how should research and data collection during these emergencies be directed to aid in refining and improving vector control strategies in the future? Just talk to us a bit about those general aspects, please, Professor Tahir, if you don't mind. Professor Tahir, I'm not hearing you. You're on mute, actually, Professor Tahir. So just unmute if you can hear me. Professor Tahir.
Seems like, sorry to interrupt, seems like Dr. Mokhtar is using Professor Tahir's Zoom link, so that's why you see here as Professor Vishan Tahir, but actually it is Dr.
Wulan,
Mokhtar.
I can hear you talking, but I can't hear what you're saying. So, but it seems like Professor Tahir is not available. So, Dr. Tariq, do you want to respond to that question, maybe?
Sorry, can you hear me, Leo?
Who's that speaking? Is that
Dr. Tariq.
Dr. Tariq? Yeah, thank you. Wonderful to hear your voice, Dr. Tariq. Would you mind responding to that question? Did you hear my question?
Yes, yes. So actually, during the emergency situation in last year, we used the BTI that actually give a excellent result against the larvae. And also we have noted that there were a lot of dragonfly, damselfly, and the other predator like the giant water bugs and also the water strider were there. So they were feeding on the larvae, and they were also helping us, and we are using the BTI that didn't damage them too much. But for future work, I think so we must have to use the different kind of drones which can be used to sample the larvae from different flood affected areas. And also we can see the actually we can go and do the larval surveillance as well as, and also look toward the other predators which are all naturally available on those flood affected areas. And during that flood, we respond with the BTI that has a very good, excellent results. And for future strategies, we should include the drones, so we can easily apply insecticide. Also we can use for fogging, and also to spread the any granule applicator like BTI. If we have a gran or Temifas, we can use. So that must be included in the future vector control strategy.
Yeah, thank you, Dr. Tariq. Just explain to me, in what specific ways were you applying the drones? Is that for habitat location, breeding site location, or were you actually using them for... Okay, talk us through that, Dr. Tariq.
Yes, actually we can use different kinds of drones. First one, the drones that can work perfectly in the flood, which can collect the larvae from the water. So we can use those drones for larval surveillance. And then we can also different kind of drones we can use to spray or to use for fogging of insecticide. And also we can use for surveillance, and also to deployment of the bed nets in remote areas with the help of those drones. And luckily we have here our department at our university. We are looking toward those technologies in future, so we can build those indigenous technology here in Pakistan. So for future we have or incorporate that drone technology in our mission.
Thank you for that, Dr. Tariq. That's fascinating. So it's actually a very sophisticated potential of deployment of drones for multiple purposes. It's not just the commonly accepted understanding of drones being used for mapping purposes, detection of breeding sites, You can actually do larval sampling. You can use them for deploying insecticides and even delivery of bed nets. Absolutely fascinating to see how the different methods of using drones can be applied. Thank you for that. A question for Dr. Kutbuddin Kakar, if you're available, Dr. Kakar. In the case of the Pakistan floods, what were the primary challenges faced in implementing effective vector control measures? How did you overcome these logistic hurdles, such as accessibility to affected areas, resource constraints, while then also managing vector control during this emergency? Just talk to us a little bit about these different aspects, the challenges that had to be faced, and how you overcame them. Please, Dr. Kakar, if you could.
Thank you very much, Dr. Liu. Can you hear me in my voice? I think I missed my turn, during the last question. So is my voice is audible now?
Yes, it is. Please go ahead, Dr. Kakar.
First of all, Dr. Liu, I think in this although it's the webinar of the experts, and we have a lot of audience, relevant to the malaria various fields. I think we need in-depth analysis, that has to be shared, of the situation which developed last year. There were certain factors which will cover the role of the climatic change, in the resurgence of malaria to this level. This, as Dr. Mukhtar said, that we had the worst ever reported malaria outbreak after 1973. So this was the second time, we had this. But we had never seen such a long outbreak, which is still continued. It is almost now more than 9 months, that since last August, it is almost a year now. We are in August since the outbreak actually occurred in August, and it was detected in September. So the challenges faced, was in the detection of the outbreak. We had DHIS2 reporting mechanism and the dashboard in place only for the intervention districts of Global Fund, which had no capacity at all to help the programs and the partners in the detection of the outbreak at the earliest possible stage. So the first challenge we faced last year was actually the timely detection of the outbreak. And then what was the success story? The first step was actually to transform this this monthly reporting system into weekly reporting system to monitor the trend of the disease on the weekly basis. So this was the first, for an outbreak response, the first step is actually having a strong surveillance system in place to have the capacity for early detection of the outbreak, which was not the case. So that was actually, it did affect our response in many ways. The first was that the application of the vector control interventions which are recommended in the earliest stage of the outbreak were not actually the recommended interventions in the later stage of the outbreak. So it did change our intervention choice, so this was the first challenge. The second challenge was that, there were a lot of duplications resulting from this this devastating flood, because the partners mainly were engaged in humanitarian action, not in malaria outbreak response at the initial stage of the outbreak. And when they came across, about the worsening situation of their of malaria during their humanitarian response, they did communicate this on 8th of September last year to WHO that that we experienced such situation which we had never seen. We were not prepared for that. So for that, we did start the investigation. As Dr. Mukhtar said, the second step was the investigation of that reported situation through the involvement of partners and global experts. You may have learned about that. We had our regional advisor, regional team, and Dr. Stephen from Geneva headquarters, GMP Global Malaria Program. And we had the assessment, both the composition of the team was of the vector control experts and the epidemiologists and malariologists. So a situation analysis was made, and that actually helped us to analyze the situation and to select the right option, at that stage of the outbreak. And according to the initial estimations, we were expecting that we will be having more than 3 million cases during the transmission season of last year, within the 3 months, 4 months transmission season, which is a seasonal peak every year we encounter. No, so that and we were actually expecting 30 to 40,000 deaths, last year as a result of this huge outbreak. But what did work, that we didn't have this mortality level. That is another, our colleagues have covered to some extent, I will show you. So first of all, in what way, the climatic change did affect the transmission potential of malaria and other vector-borne diseases. We are talking about the prevalent vector-borne diseases. Since there was an upsurge of the prevalent diseases, not a new disease which was introduced last year, dengue is actually the problem of the urban settings in the country, and particularly in those areas where we don't have malaria. So that is different scenario, that if we have to analyze, the impact of the climatic change on the transmission of dengue, then we have to be a little bit more technical about that. The major impact came, on the transmission of leishmaniasis and the malaria, in the upsurge, So there is a question now that, as mentioned in the presentation of Dr. Mukhtar, that during the last decade, we had a declining trend of malaria in the country as a result of intervention supported by Global Fund mainly. And it was this estimation was made not on the basis of the reported incidents, it was based on the reported suspected estimates, the estimates for the suspected cases, which in my opinion, I didn't agree neither with the GMP, neither with our own programs, that, if we had to measure the impact of the interventions, then we should have to see this, as an outcome of the interventions in the form of the test positivity rate reflecting the reservoir, which is being built up. The second is that, we have already set a target of incidence in reduction, not the reduction in suspected estimates. So that was actually, even then, we were in a state, that on average, we have been reporting 370,000, 50,000, and 80,000 confirmed cases on a yearly basis. But what changed the scenario last year, that we had 3 million cases, just within the span of 4 months, from September. What was the reason behind it? It was only the climatic change, Definitely, yes, but in what way it did impacted that, so that we have to see. I will tell you that question response as well. So it will cover by your question as well, that the challenges we faced. Since you are focusing on the vector control response, I am having a little bit broader, the range of the events, which will actually explain, which I think were not explained in big length. So first of all, the climatic change, resulted in unprecedented flood, which was not even precedented by the weather forecasting departments. We were not expecting this level of rain in those areas which were already under drought condition for the last 8 years. So having a prolonged drought followed by heavy rains, which was 60 times more than the rains we had in the last many years. So that was one impact. It did help, in increase of it did support the increase or the exposure to susceptibility susceptibility factors, On the other hand, it did result, in the vulnerability risks, as well, So susceptibility risks was actually the favoring of the environment for the density built up of the prevalent vectors. So that was an opportunity for the vectors, to build up, its density to the levels which increased the susceptibility, of the population to have the infective bites. It should not have happened if we had no reservoir in the population of the parasite. So parasite reservoir was existing in the population at the maximum level, which was, I think, either undermined or was not reported or reflected in from our incidence reporting. We have many limitations, from the existing information system. Most of the time, once we implement a project, so we have a lot of priorities for our project interventions to have the target achievement, that is the first priority for us, But I think sometimes we make mistakes, in that, because the endemicity of malaria in Pakistan, if we look into that, it's a poverty-driven problem in the country. If you will go to the developed province of Punjab, you will not find malaria. But if you will go to the poorest of the poorest provinces in the country, you have the highest endemicity. Here, the health system doesn't work, where the people, they have access to quality diagnosis and treatment services and to access to the effective vector control interventions. So this is, that was a challenge and flaw in the reporting mechanism in the information system. So one, in my opinion, was the presence of high reservoir in the communities which were affected by heavy rains later on and by heavy floods in the agriculture plain of Sindh province and southern Balochistan. In the northwest Balochistan, the regions which are bordering with Afghanistan and Iran in the west, and with the coastal Arabian Sea belt in the south, these were the areas which received the rains, not the floods. The floods were actually the flushing ones, but which actually cleared the breeding sites, at the initial stage, but it resulted, in the continuity of heavy rains, and which did favor the breeding in the coming days. And that's why, I have a slide today, you can see, that after 9 months, we have rising mortality from falciparum in the south, in the northwest districts. Yesterday there had been a big demonstration of the people.
Dr. Kakar,
the major challenge, last year was in the vector controls, Dr. Lever, actually, we didn't plan, for this long calamity, to be expected, So we were not well prepared in terms of
Dr. Kakar, I'm going to have to ask if we can wind down the response. So we need to give the audience a chance as well. Could you wind up, please, Dr. Kakar?
Yes. So the major challenge was actually the availability of resources for the effective vector control, and that was the major reason, And since we have a vector control tool, only the long-lasting nets, and long-lasting nets have been proven to be the most effective tool in various situations, epidemiological settings, but not in all settings. There is actually the behavior of the population, about their sleep habits, about their use of the nets, it does also impact that. So we were reliant on the LLINs, and we had dropped the IRS and larviciding. We had never used larviciding, in our past vector control interventions. So this time, we did go for innovation.
Dr. Kakar, thank you so much. Those were very valuable reflections, lots of wisdom that came through there. We understand, it's a unique situation with a very complex mix of factors contributing to that, making it very difficult to respond to, and yet Pakistan did so well. Thank you so much. I apologize for interrupting you, Dr. Kakar. You were really on a roll there with wonderful information, but I have to try and be fair to our audience as well and get some questions from their side. So apologies for interrupting you, Dr. Kakar, but wonderful reflections you gave us there. Thank you for that. So I'm going to I have to, we've run out of time, so I have to go to the audience questions, but also to mention to our audience members, we will take all your questions. We're not going to be able to address many of them, but take all your questions, send them to our panelists and ask if our panelists would be so kind as to give short responses to your questions, and we will email them back to you. So the first question I have here is from Pallavi Lal. If I observed correctly on your slide, we saw a peak in malaria cases until the end of 2022, and then a sharp decline at the start of 2023. Can you explain to us the epidemiological basis for that? Is it just, breeding sites were no longer optimal? Dr. Mukhtar, do you want to respond to that question?
Yes, Dr. Liu, ideally, I referred this question to Dr. Kak, and but initially I will give a few thoughts on it. That yes, but if you look at the case load which I showed in my presentation, yes, this slide, that you can see that there is a no. Who is sharing this slide? I think Dr. Hello.
I'm not sure who's
Yes,
sharing
Dr. Mukhtar, it is for you. I think the question was linked with this.
Yeah.
The initial, in the month of January, the decline was actually expected from December last year, as we have the decline as usual in the transmission, in the month of December, January, February, which are the winter months. And these are the coldest months, in the highest endemic part of the country. And that is usually seen. But unfortunately, if you will look into that, we did continue to be in the outbreak situation even in the months of January, December, and February. Look into the 2022 January, we had 10,664 cases, while we had 112,611 cases in the month of January. So we did inherit, an intense transmission from the last year. So definitely, the explanation is that although it is not an active transmission, but was the relapses, the recrudescence of falciparum and vivax cases in these months, which continued, due to unavailability of the essential care to those people, during these months, so we had this, inherited decline from the last year, but maybe not a true transmission. The true transmission actually started from the month of March onwards, which is the spring peak, we normally have. And it also increased manifold. If you will look into the month of May and June, compared with the month of May and June.
Okay, Dr. Kakar, thank you so much. We have to move on to other questions. But I think, you've explained that the general pattern reflects the historic seasonal trend of, the cooler winter months, you get a decline in transmission, lower numbers of mosquitoes, although numbers were higher for those particular months than the equivalent months in previous years because of residual breeding sites, a bigger parasite reservoir in the population, all those reasons. But there is still the underlying trend of seasonality in there, which will probably take, a year or so to work its way back, hopefully, to historic lower levels as control kicks in, both against the parasites and the vectors, and the residual breeding sites decline as well. So The next question is about resistance, insecticide resistance status, and if that may have played a role in the increased case numbers. It's almost certainly unrelated, but maybe just give us Dr. Mukhtar or somebody give us an idea of the status of insecticide resistance in malaria vectors in Pakistan. Of course, it's changed because it's no longer Culicy it was Pulcherimus that was involved. Any comments on insecticide resistance, Dr. Mukhtar? Or anyone?
Mukhtar, sir, can I reply on that? Where is Mukhtar?
Sorry, who's that responding?
May I respond on that?
Yeah, please go ahead.
Actually, we don't have the insecticide resistance monitoring as a regular feature of the program. Because of
are you responding this question?
I have started responding, then you will respond.
Okay.
So first of all, you know that this is because of the resource availability, the role of the provincial programs, in to coordinate in this activity. But one of the best, progress we made last year, since the Directorate of Malaria Control were leading the role in this on the vector forefront as well. We had the assessment, of the vector entomological situation, before the intervention and after the intervention, and that actually, although there was not direct monitoring of the insecticide resistance monitoring, we have planned for this year. Dr. Mukhtar is actually leading that, but I can hint out about the findings, of our intervention. Did they work or not? So the answer was that in some areas it did work, like in Dadu district, in Sohbatpur district of Balochistan. The areas which we did cover, with the insecticide residual spraying, we did bring immediate decline, in the incidence, and the density of the vectors. But there were some areas, pockets, like in Kambar Shedatkot and Ladkana districts of Sindh province. We had the same intervention and in the same epidemiological situation. So we had not the desired results. Currently, both Kambar Shedatkot and Ladkana, the same localities, they immediately developed the same transmission potential after few months. So the impact was not that much evident as we had seen in other districts. So probably we have a different scenarios of insecticide resistance, pockets of. In my opinion, I'm wrong, Dr. Mukhtar will actually reflect that. He has the surveys, the record of the data of that. But in my opinion, we can indirectly measure the impact of vector control in terms of measure, the resistance level, maybe the quality of the use, although it was the same. So I can say, that it is not, the across the country, but there are parts of increased resistance maybe, it is us of having insecticide resistance monitoring to be an integral part of our entomological surveillance. In my opinion, I think it is highly needed now. Over to you.
Yes, Dr. Kakar, thank you for this point. Yes, if I go to specifically to the question that there are some reports of the resistance from the some pocket. I totally agree with Dr. Kakar that is not across the country. That there are certain pockets where we have reported the resistance, and we have the last big survey in 2008, 17, 18, although it's a little bit old survey, but we should monitor the resistance a yearly basis. But till the available data have that there are certain pockets, that a certain district in the Sindh and even in Kipik and Balochistan, where there we have reported the resistance against particularly the pyrethroid and OP group, but not across the country. That's why there is sometimes your intervention is working and sometimes your intervention is not giving the desired results, as Dr. Kakar is mentioning. So the resistance is not the problem across the country, but there are some pockets, small pockets, not small pockets, but there are some pockets where we have reported the resistance against particularly pyrethroid and OP group. Over.
Is that in Kilisifasis, or did you actually do it on
Sorry.
Palkarimas?
Yeah, sorry, it's actually the Stephen's eye and some pockets Kilisifasis, mainly in Stephen's eye. And it's very interesting that Stephen's, though we mentioned that Stephen's eye is a secondary vector of malaria in Pakistan, but there is a debate on its status of the vectorial capacity in Pakistan. Mainly, the tests were conducted against the Stephen's eye. Kilisifasis, there are few tests were conducted in the southern Punjab that the Kilisifasis found still susceptible to the pyrethroid and particularly pyrethroid group. So we are comfortable with the pyrethroid even in case of the Kilisifasis, but Stephen's eye showing some resistance in some pockets of the country. Over. But pool carriers, because the pool last year we collected the pool carrier for the first time. Though it was first time recorded in 1964 from Pakistan, but it has never been reported as a vector of the malaria in Pakistan. But last year, first time we found the huge population of pool carriers and totally absence of the primary vector. And what are the proxy indicator was showing that because the pool carriers were fully blood fed, it was collected from the living rooms, of sleeping rooms. So all these proxy indicators were showing that it has a great potential of the new malaria vector in Pakistan. And what the sample analysis from the CDC Atlanta also shows us some positivity of the human blood fed, which indicate that Kilisifasis also, pool carriers is also showing it's a vectorial potential in country as a potential vector of malaria in Pakistan. But we have not yet conducted any susceptible test against the pool carriers.
Thank you, Dr. Mukhtar. Fascinating, absolutely fascinating information. So another question here is around which parasite was primarily involved. Is it Vivax or is it Falciparum? Anybody able to respond to that? Presumably it was Vivax, but can somebody confirm that?
Yeah, it's mainly what the Vivax, but in some pockets of the Sindh province, we have the huge proportion of the falciparum as well. So for the epidemiological assessment, Dr. Kakar was taking the lead, so I think he can give the better answer. What information I have as a national level that mainly it was the Vivax, but there were certain pockets, particularly in the some districts of the Sindh and Balochistan, there was the falciparum was also showing a very high proportionate of this parasite species. Dr. Kakar, do you have any comment on it?
Definitely, I have a comment on this, just to add what you have said. Can you hear me all, clearly?
Yes, please go ahead.
So everybody, I think, who is interested with the disease epidemiology of the country, they know about the prevalent species of malaria parasites. Both we have Vivax and Falciparum. There are, the geoepidemiological areas, where we have in some areas Falciparum as a predominant species. In others, we have Vivax. But Vivax is prevalent, across the country. Wherever we have malaria transmission, we have Vivax, in various proportionate, ratios. But in recent years, due to the introduction of ACTs, from 2008 onwards, I think we did bring a big in the Falciparum prevalence, and that actually brought down the incidence of Falciparum to less than 20% in the overall confirmed cases. So the predominant species remained Vivax malaria. But if you will allow me just to speak few words, it is very interesting, how the what was the situation last year, we had the upsurge of falciparum malaria not only last year, but from 2019 onwards. There has been visible rise in falciparum incidents, which actually reached to the peak last year. In falciparum endemic areas, like in rural areas of Sindh, we had certain districts belt where it reached to 80% of the total positive cases. In Balochistan and in the south, 3 districts, we had falciparum up to 70%. But
right.
you know, the strange thing which we did experience with Vivax malaria was the complicated and severe form of disease, you know, which has been seen, you know, with Vivax malaria during the outbreak of last year and this
Dr.
year.
Kakar,
So this
we
is, you
need
know,
to move on. Unfortunately, I need to move on. We can't dwell too long on any one question.
move on.
So thank you, Dr. Kakar. So there's a question here about the role of fogging. Can anyone provide some information to what extent fogging was used, and was it against malaria vectors or was it more against dengue vectors? Any comment on the question around the use of fogging during the emergency?
Thank you, Dr. Liu, Mukhtar, because I am the writer or co-author of the national guideline for the dengue control, where the fogging has been described in a very detail. Fogging is normally actually not recommended for as a routine intervention. Either it's for the malaria or for dengue. It's only a contingency plan or emergency outbreak response, a part of the outbreak response plan. However, the people normally say it's a political weapon. It's not a political weapon. It's a highly effective intervention when it is done according to the true principles of fogging. Like during the outbreak, we recommend as per national guide, international standard that if there is outbreak, you have to conduct the fogging in that particular area on alternate day for 1 week. For second week on every third day. And fourth week, because actually the emergency situation will finish on the fourth week, but third week, but it will be conducted on weekly basis. So fogging can be effective as the emergency response when it is done on the true principles of the true principles of fogging. Like as I explained that on alternate day during the first week of emergency or outbreak, third day on the second week, and third and fourth week is weekly basis. So fogging can be effective when it is used according to the principle. Otherwise, fogging is not an effective tool when it is just to have a fogging once in an area and then you disappear for months, and of next month you can again come for the fogging. So that will be not the effective intervention in that scenario. Over.
Thank you for that clarification. Great explanation. Thank you, Dr. Mukhtar. So there's a question here about a person asking a little bit of clarification. What is the problem with using the square nets in the emergency humanitarian accommodation, and why would a conical net be preferable? I know but could you just clarify for some members of the audience, please, Dr. Mukhtar?
Yeah, we wrote in a detail. We wrote a very detailed in some article that the rectangular shape of the bed net, because you know that the tent is a wedge shape or triangular shape, and the upper part after the 2 feet height at 3 feet height, its area is very narrow, and when you have the rectangular bed net whose width is 160 centimeter, and while the total width of the tent is not more than 60 centimeter of the 3 or 4 feet height. So that's why due to the small size of the tent and its triangular shape, it is not possible to hang the rectangular bed net inside the tent. Conical bed net, why we prefer in such scenario, because that is you just want to hang the bed net in the center of the tent, and you can you can spread it's far around the tents. That's why, due to this reason, because we have a survey, though it's an old survey in 2012, the rate of utilization of the conical bed net was almost 92% as compared to the rectangular bed net, which has only 34%. So just because of the shape, smaller size and shape of the tent, and the shape of rectangular shape of the bed net, the rectangular bed net is not suitable for the use of the inside the tents under the emergency situation. Over.
Wonderful. Thank you for that clarification, Dr. Mukhtar. Our last question, because we are now way over time, our very last question, but please remember, we will send all the questions to our panelists and ask if they would kindly respond to the questions, and we will send it out to our audience members. I also want to ask, this is the last question, but before you go, there's going to be a short poll that we put on the screen. Please, could you it takes 1 minute of your time. If everyone can just try and respond to that poll, it really helps us. So, okay, here's another interesting question that pops up. But the other question I wanted to ask is, and it's directed at Dr. Tariq. You say you used a BTI in the flood emergency situation. How did you determine the impact of the BTI? I think you said BTI was used to great effect. What are you basing that to great effect on? How did you measure the impact of the BTI? Dr. Tariq, if you're still with us, could you just give us a couple of sentences in response? Okay, it doesn't look like Dr. Tariq is available. Anybody else that may be willing to venture a response as to the impact of Bacillus thuringiensis israelensis and measuring the impact of that application of BTI?
Yes, Dr. Dr. Liu, I can give the response on these very important questions. You know that why we promote the BTI, particularly in the flood situation, because you know that you don't know the final destination of water. It can go to some drinking water. That's why we were avoiding the use of the traditional chemicals. How we evaluate its efficacy? Yes, in these areas where we applied the BTI, because it require a frequent retreatment, treatment of the stagnant, because the first treatment will give you the efficacy up to 7-10 days, and then 15 days, 18 days, and then you have to reapply this BTI. And it can give you the up to 43 days control after the second or third application. For the efficacy monitoring, that yes, we when after the application of the BTI, we have to regularly monitor the first, because BTI is most effective against the third and fourth instar. So first and second instar, which is actually newly emerged from the eggs. So that's why we have to regular monitor the efficacy of the applied BTI in the affected areas. I was a part of this one study where we regularly monitor the BTI, and we found it's very, very effective as compared to the traditional Tamifos or Fenthion insecticide. So BTI is also is very effective particularly in the emergency situation, because it is easy to apply as compared to traditional chemicals, and definitely it need the regular monitoring, initially regular monitoring of it to efficacy, that how much the BTI is effective. But when you have set the baseline or the benchmark about its efficacy, then there's no need for the further monitoring regularly. But BTI is a very effective, particularly in emergency situation, and initially we have to monitor its efficacy for monitoring the third and fourth instar larvae, the things like that. I have, am I replied to your question? If there
Yes.
is not
No, that's
clarity,
okay.
somebody can write me email. I can send it the further more clarified answer for the understanding.
I think strictly speaking, the person was asking, how did you monitor the impact? Did you go and do resampling of the pools to which you applied BTI and checked for presence, absence, abundance of larvae in those pools? How did you measure the impact of the BTI? I think that was the question.
Yeah, yes, because as I told, that BTI is a very new intervention in the country. We started its use in 2021, and then on very limited scale, but in 2022 on a little bit larger scale. Definitely, because it's a new intervention, we have to monitor its efficacy regularly. Like after the application of the insecticide, we have to revisit the same area after 7 days, then 14 days, then 21 days, and 24 days as a first application. For second application, same on weekly basis, and this is the mechanism, standard mechanism for monitoring the efficacy of the BTI.
Okay. Thank you, Dr. Mukhtar. Thank you very, very much. There's so many fascinating questions, but we could go on for the next 2 hours, and obviously we don't have the next 2 hours available. Really good questions. I want to express my sincere gratitude to Dr. Mukhtar for his wonderful presentation, to our panelists for your patience, for the very clear and professional responses. My sincere apologies to Professor Tahir for the lack of opportunity for various reasons that we couldn't get you to spend more time responding to questions, but to our panelists and also to our audience, wonderful questions. So, I mean, there's still 114 of you present. Resilience in staying on despite more than 2 hours now on this webinar. My sincere thanks to Pooja, Dr. Borne, to Wulan, our technical team in the background that made this possible. So to all of you, our panelists, our audience, our technical team, my deep gratitude to all of you for making this such a fascinating, interesting, and very valuable webinar so that we can learn from that extreme event that happened in Pakistan last year. Sincere thanks to you all. Thank you. Please respond to the poll if you don't mind. We would be grateful for that. But thank you sincerely, everyone. Bye-bye for now.